Hello, everyone, and thank you for joining today's exciting webinar hosted by the American Heart Association Center for Health Technology and Innovation. We're thrilled to welcome you to a forward-looking conversation on the next generation of telehealth, a space where innovation, equity, and access converge to shape the future of care delivery. As virtual care continues to evolve from a convenience to a cornerstone of modern healthcare, today's panel brings together a remarkable group of leaders, clinicians, technologists, and policy experts who are driving change at the intersection of digital health and patient-centered care. Today, we invite you to lean in, learn, ask your questions, and imagine what's possible as we shape the next chapter in telehealth together. As a reminder, if you have questions, please put your questions in the Q&A section of this webinar. Let's begin by welcoming our distinguished panelists. I'm going to let them introduce themselves. If you would, please state your name, your title, your affiliation, and briefly what you do. And let's begin first with Lonnie Riley.
Thank you, Cheryl, and thanks for having me. Happy to be here. I'm Lonnie Riley. I'm the VP of Industry Affairs at the American Telemedicine Association and ATA Action. I work with our clinicians regarding telemedicine and virtual care in general. And on the action side of the house, I work in policy and advocacy on the Hill. So happy to be here and looking forward to the conversation.
Wonderful. Stephen Randall, we'll have you introduce yourself next.
Hello, Stephen Randall. I'm founder and CEO of Medeka. We're a medical intelligence company with an FDA-cleared telehealth platform that combines low-cost sensors and AI that translates acoustic biomarkers into cardiopulmonary insights. And on a personal note, I'm calling from Henderson, Nevada. I'm the proud owner of 2 stents with a history of heart disease, and accidentally became a poster child for my platform when our AI discovered that I had early onset of aortic sclerosis, something that my ex-cardiologist didn't discover. So happy to be here as well.
Thank you for sharing your story. And lastly, but not least, Dr. Jeremy Green. Would you introduce yourself, please?
Sure thing. Thanks, Cheryl. I'm Jeremy Green. I'm a physician and a historian. I practice internal medicine. I'm actually here at the East Baltimore Medical Center, a federally qualified health center where I practice in community health. I also direct the Institute for the History of Medicine at Johns Hopkins University School of Medicine and co-founded the Center for Medical Humanities and Social Medicine. I think part of the reason I'm here, and I'm not trying to sell this to you, right? Like, I don't even know if I can get it in view, but there's a book called The Doctor Who Wasn't There. Nope, I can't. It'll only obstruct me. Technology History and the Limits of Telehealth. This is a historical study of the antecedents of telehealth and what we can learn from past platforms to deliver care at a distance and how they can help us speculate and think concretely about what future technologies promise.
Wonderful. Thank you so much for sharing. Well, we're going to go ahead and kick our discussion off. I'm going to begin with Stephen first. Stephen, how are AI-powered diagnostics and remote monitoring transforming early detection and chronic disease management in virtual care?
Yeah, it's a really good question. So AI, the hype of AI is often around LLMs, but it's much broader than that. So I prefer to talk about multimodal AI. So that's not just looking at text, it's also looking at the digital signals that could come from an EKG or the acoustic signals that come from digital stethoscopes. And in telehealth, at the moment, that's not been leveraged particularly. I would like to say that what I call Telehealth 1.0, which is where we are today, is more or less a FaceTime conversation. And I call it convenience care as opposed to capability care. Where AI is going to come in is using the same channels, the same audio channel and video channel to actually turn Telehealth 1.0 into 2.0 capability care, where you can actually reproduce the advantages of an in-clinic exam remotely. And that we've seen some small rollouts of that. It's very challenging from a telehealth platform to make that affordable and easy to use and plug and play. So the challenges are not just technology, they're also in the user workflow and in the cost side of things. But now there's no technical barrier. It's more of an education barrier and a cost barrier. So AI is able to diagnose everything that a doctor can hear and everything that a doctor could see. It can help. And obviously the cliche today is that AI isn't going to replace the doctor, but a doctor with AI might replace a doctor without AI. So at a very high level, broad perspective, AI is enhancing early diagnostics. And obviously some sobering facts. So a wonderful quote from Dr. Eric Topol, who says doctors are pretty good at discovering and helping and preventing your second heart attack. But there's roughly 800,000 heart attacks a year, of which 600,000 are your first heart attack. So we want to use AI and other diagnostic tools to help patients be proactive in knowing your first heart attack could be a possibility. Much like a car engine warning light doesn't let you drive until the engine breaks down, it gives you a pre-warning. We need a car engine warning light for every human being.
That's excellent. What a wonderful response.
Thank you.
Jeremy, can you share examples of how integrated platforms are improving clinical workflows and patient outcomes?
So, I mean, I can take us back into some of the promise that was made of this earlier, and I guess it's one of the challenges not only of telehealth broadly conceived, but also the general landscape of what digital platforms promise to do for care. So, part of what I try to bring to this kind of conversation as a historian is the sense that things we think of breathtakingly new in the present day have actually been proposed before with greater or lesser concerns. And that actually things that we think of as old and mundane are oftentimes the outcome of truly transformational, technological platforms in medicine. So, this is not about computers, but if you think about the telephone in medicine, which I think we rarely do, right? Because we tend to understand that just the ability to call a doctor's office is simply part of the framework of modern life. But when the telephone was first introduced, the excitement around what it could do to deliver connected care, and even along models that we actually see in the present day, the development of new peripheral technologies. Like I could show you an article from Scientific American in 1915 about a stethoscopic chest piece that could be screwed onto a telephone so that cardiologists could diagnose at a distance. And the kind of breathless predictions in this moment were, on the one hand, now everybody can access cardiologists regardless of where they are in the country. The fearful moments are, of course, suggesting, well, cardiology may be entirely undone as a profession, and instead there will be this new specialty of telephone medicine, and these residencies in telephone medicine will replace residencies in cardiology. Of course, neither of these things quite came to pass, right? But what did happen was a fundamental infrastructural change that reshaped access and also automation and algorithms, because the first algorithms deployed in American medicine are actually scripts given to nurses that are actually manning telephone banks to help manage symptomatic complaints, often of pediatric patients. I'm giving that as an aside to say, actually, we see integrated platforms that roll out in pre-computer spaces that are actually doing a lot of the work that we now transpose onto computers. Now, continuity and change are both tools of the historian. People oftentimes suggest, bring out this quote that those who fail to learn from history are doomed to repeat it. And historians don't tend to think this way because history never really repeats itself. We tend to favor the line by Mark Twain, history doesn't repeat itself, but it often rhymes. So the question is, what is similar and what is different about the present from that past moment? So this is all by way of suggesting that in the early 1960s, even in the late 1950s, folks invested in the potential of what computational systems that are integrated across a variety of academic medical centers, tertiary medical centers, and primary medical centers can do to create a total platform of care that can connect the practicing physician with a newly electronic medical literature and a set of algorithms that are readily available to help them diagnose better. Vladimir Zworykin, who is actually the vice president of RCA, founds the first Center for Electronic Medicine associated with the Rockefeller in New York. And they're promising this moment in which the electronification, digitization of a seamless medical platform will deliver care and break down all these barriers of knowledge. And that AI, because they're calling it AI then, remember, this is before the first AI winter, will actually help make the physicians' work more human by actually taking a lot of these drudgeries away and allowing for computational power that is impossible by the human mind alone. Of course, none of this happens. And so the question in trying to understand what did happen, how did the computer change medicine in ways that we don't see, just like the telephone changed medicine in the ways that we don't tend to see, is in some ways more instructional in trying to look at what will AI actually generate. It probably will not generate all the promises being made right now. It almost certainly will not, but that doesn't mean it won't be transformational.
Excellent response. Thank you so much for your historical perspective, and it's one wonderful perspective. Thank you so much. Lonnie, how can telehealth be designed to better serve rural, underserved, or aging populations?
Thanks for the question, and I feel that we can all weigh in on this particular discussion. I think it's, very transformational for rural areas to be able to access healthcare in the same way that we would access healthcare in an urban setting. I think the design is there. I think what we need to think about is, the readiness of those rural communities to be able to integrate that design into them. There are really great tools out there that, can help folks to understand where their readiness lies, whether it's, speed, cost, and the infrastructure that's, integrated into the community. Are you ready to, bring telemedicine, AI, all of these wonderful digital tools that we now have into the community that will benefit from them most? We're looking at the ability for, states to apply for, some really great funding via the Rural Transformation Program here. And I'm not going to go too much into politics, but, I do sit at the ATA action, so it's hard for me to avoid it entirely, to bring these types of tools into areas that, again, need them most. So I guess what I would say succinctly is that the design from our innovators is there, and it is being thought of for those patients that need it most. It's how do we help those communities to bring that design in and integrate it into, their lives. So I'd love to hear everybody else's perspective on this, because I think it's an incredibly important topic.
Stephen or Jeremy, would you like to weigh in on that? It's a fascinating question, and thank you so much, Lonnie, for your response.
Well, a couple of things. I think a lot of people assume when they think about rural or even the aging population. I like the phrase the silver tsunami, because I think we're in that. I think 1 in 5 people in America now is over 65 years old. But a lot of those people actually were not that old when the internet started, and they're very familiar with technology. So I think there is a kind of an arm waving notion that, well, these people aren't maybe very technical, but I think most of them are. Of course, there are still challenges getting decent internet to everybody, but I think those challenges are mainly being solved. So I think that the opportunity to connect, certainly by smartphone, but through something that's a decent connection for video health, is not in itself a technical challenge. It's often an excuse. The bigger challenges in the elephants in the room are to do with the who's going to be paid for that call. Is it going to be remunerated at the same level as an in-clinic exam? So I think often the technology isn't the blocker. The infrastructure is there, and I think a lot of this is a willingness to understand that there may be more efficient ways of connecting to a patient earlier using this technology, rather than assuming, well, they're too old, or it's too difficult, or the internet connection won't be good enough.
Yeah, I think the platform is fantastic. And Stephen, I appreciate your concept here that oftentimes we think, is the tech good enough or not? But that's not necessarily the fundamental problem, right? The fundamental problem has a lot to do with political will and with systemic viability and with attention to questions of who's, that reflex of following up on, is the promise that is being made for greater access and better quality and reduction of health disparities actually being delivered on? And that's not a tech problem, right? That's a sort of a social technical, like, how do we follow up on whether actually the promise of this technology is being delivered? I'll just illustrate with one other example, which is, something that fascinates me about looking at telehealth from its origins is that you have this moment in the late 1960s, like, one of the first telehealth clinics is founded in Boston, in MGH, Dr. Kenneth Bird, who's reading Marshall McLuhan, very interested in the media theory of his time, sets up a satellite clinic at the Logan Airport and uses it as a laboratory for seeing, can we deliver quality care in this environment? Where is it similar and good enough? Where is it not good enough, right? And then in that context, how can we then use that to think more generally about how communications technologies and platforms enable greater access and equity to healthcare? So this is this expansion that then happens in the 70s, right? There's a set of pilot projects. Many of them are funded by the United States. There's public health service. There's a number of different programs that check not only rural areas, but also urban areas, right? So the question is, in a way, how can telehealth as a platform actually bridge problems of disparities in access? And rural problems are one very concrete thing, right? You've got sparsity. There's a lot of attention to what is happening as physician populations are leaving rural areas for urban areas, as the kind of biomedical deserts in rural, and this idea that distance is the problem, right? And whereas in urban centers, distance is not the problem. There's other problems of geography that bound access to care. In both settings, I think one of the things that you learn from the telemedical trials of the 1970s in rural and urban areas is that uniformly telehealth works, right? It does deliver in giving meaningful access to care to people who otherwise would not actually have it. But what actually enables these telehealth successes is not the technological setup, right? It's actually what kinds of structures of care get generated. A lot of it has to do with the ability to mobilize, what then later become mid-level or advanced, access providers, right? So nurse practitioners who are actually struggling in this moment to gain the ability to prescribe and actually treat patients as autonomous agents while also being supervised by physicians within a structure, find that telehealth links enable them to act autonomously. So in so many ways, what the platform is really doing is mobilizing a workforce that had actually been repressed within the healthcare system, and that telehealth enables that to happen as well. So what's fascinating when you look at this is that rural and urban happen side by side, but fundamental lateral structures, which are not about the tech itself, but about the social organizations of care that are permitted underneath it, actually take shape in this space.
I'd actually like to enhance something you said. Excellent points, Jeremy. It's also not just the technology, it's the ease of the use of the technology and the trust in the technology. So the technology might work, but just to take a very simple example that you used from way back, plugging a stethoscope into a phone, and now a remote doctor can hear heartbeats using that technology. That's great, but when you're on a telehealth call, you're now speaking to your doctor through a stethoscope. So now a doctor has to kind of be aware of that and then say, oh, if I'm going to ask you a question, how long have you been having these chest pains? You need to lift the stethoscope up and speak to through the stethoscope, which is a very unusual user experience. Or the doctor's got to switch something on their end, so they've got to learn something. So again, the technology works, but if the user experience isn't seamless and obvious, it won't get used. And if the doctor's got to spend more than a few minutes doing that, it's going to stay on a shelf or in a drawer, and it's going to be a technology nicety, another shining toy that people have talked about, but it won't get used. So you have to solve problems on the user experience as well as the cost. That's another aspect that, the technology works, but if it's going to be hundreds of dollars for the patient to use, it's not going to get deployed. So all of these things have to work in tandem before you have a real shot at scaling this.
Yeah,
Stephen,
go ahead, Lonnie.
I agree so much. And I'm thinking that, that is not a set of requirements in terms of scalability that is, urban versus rural. That's across the board, right? I mean, we have a group of clinicians that we work with closely at the ATA that have spent a good amount of time on this idea of trust, both on the clinician and provider side of the house. And we're working now on, how do we help patients to understand what to look for in terms of being able to trust a telehealth platform, or how can they ask smart questions about, technology that they're hoping to integrate into their care journey. So, just agree with you and think that trust building is a huge piece of what we need to do, because, what we have are tools that we will be interacting with going forward. And I love pulling in that historical piece, Jeremy, because we've already been doing this. A lot of this isn't brand new, as you said, right? And so if we've been doing this historically, we can only look forward to, more innovation to come. And, how do we get our providers and our patients on board? How do we help them to get smart, about these tools that are going to be so integral, to us going forward?
And one piece I'd like to add in here, I agree with everything you're saying here, Lonnie. And I'm speaking here as, obviously I'm speaking as an individual rather than representing Johns Hopkins as an institution. But, I work in a community health center as part of the safety net. And so much of this early promise of telehealth was, how do we help people get into care who otherwise wouldn't be getting care? And how do we get them the level of care and expertise? Again, the telestroke unit being one of these great examples, especially in rural areas where you can document that the quality of care, the extension of care, what is gained versus what is lost through a telehealth encounter is so substantial from a public health and individual care perspective. But, here I was studying telehealth and digital and changing histories of how electronic mediation of care changed the nature of medical encounters. But I hadn't been a teleprovider myself before the pandemic. And of course, this clinic that I'm in right now, we had to shut our doors in March of 2020. And then suddenly I, like all of my colleagues here, became teleproviders. And we suddenly saw a dramatic difference in who was seeing us, right? So I work at I speak Spanish. I'd say about a third of my patient encounters are done in Spanish in this clinic. We exist within a majority minority neighborhood. We were founded, our base as a community health center has to do a lot with a history of neighborhood activism in this area. So we have an accountability to I'll see any patient that walks in the door, right? So there's no class boundaries. There's no racial or ethnic quotas in this clinic, right? But however, we understand as a safety net institution, like we will see anybody who comes in the door, and we become a vital space for people who are at either uninsured or sometimes uninsurable. So what happens is that the ability to just walk in the door disappeared entirely, and everybody that I saw in a telehealth suite was suddenly a middle class, well-insured patient. Right. And so this idea that telehealth, which was founded to increase access and reduce health disparities, was in this moment of crisis actually doing the opposite, is something we all noticed. Folks noticed this also in Philadelphia and in Boston and Los Angeles and in New York. So what do you do about it? And I'm taking too long talking about this. I'll be quiet in a second. But one of the things that I was really impressed with what Johns Hopkins did in this moment is it recognized this problem. And it started doing zip code analyses around the city and understanding how actually, even though this platform was available, it wasn't easy to use for everybody. And for some people, calling in that the telephone, this older technology, was a more meaningful technology of delivering care. And this idea, we don't think that audio only is equivalent in value to audio plus video, let alone audio plus video plus enhanced sensors that we can actually have through smart technologies in our home. But if you don't have the whole smart suite set up in your home and you have a telephone, we've got to meet you where you are. And so we worked very hard to actually develop these emergency measures and extend them so that audio-only telehealth was meaningful in this moment. So I want to suggest in this area that's not immediately apparent. It comes back to your point, Stephen, that we can do all these things, but unless it seamlessly plugs in, the actual platform might worsen disparities in access rather than make them better. And we just have to be attentive to closing that loop wherever we can.
Yeah, excellent points. Actually, I could also, I don't want to hog the microphone, but a lot of this isn't being driven by healthcare, it's being driven by the patient. So the patient, just going back a few years, wearing an Apple Watch, a lot of doctors would say, well, I don't take that seriously, it's not clinical grade. But if it's detected atrial fibrillation, it's at least a data signal to do a further exploratory exam that they may not have had the opportunity of even knowing that. And it's not just the Apple Watch, it's Whoop and all sorts of other devices that are giving people greater insight and being proactive in their health. So a lot of this is being driven from wellness, which is now encroaching on healthcare with even ChatGPT, where you can put in, say, your EKG, and instead of giving you squiggly lines and saying speak to your healthcare provider, it will actually interpret it for you. So this isn't going to be stopped. The Pandora's box is open, and the patient, both at the top of the market with self-insured people, and at the bottom of the market where people can't afford insurance, they're going to the internet, they're going to devices to find out proactively what's going on with their health. And so this is a tsunami that's unstoppable, in my opinion.
Thank you so much, everyone, for your wonderful perspectives on this question. I love all the information that you shared, for sure. Lonnie, I'd like to go back to you. You mentioned something earlier in response to one of the questions. What are the most pressing reimbursement hurdles facing telehealth today, and how can policy evolve to support sustainable adoption?
Oh boy. Okay. Loaded question. All right. Well, to be perfectly clear, so that everyone knows kind of the perspective that I'm coming from, I think the telehealth reimbursement piece will probably be able to kind of come at that from a group perspective. I came to the ATA by way of the Digital Therapeutics Alliance, and so the reimbursement kind of pathways that I've been most focused on in the past several years are for digital therapeutics, digital diagnostics, and kind of remote monitoring tools. So these all, of course, play into virtual care as a whole, but reimbursement is a big area for development, and there are opportunities for improvement for these tools, shall we say, because it is not, we don't have kind of a one-size-fits-all solution for these tools as it stands, right? So we have worked out a few different ways based on how people build their businesses around the development of these technologies for reimbursement to begin to occur, right? So one thing that we've been working on the Hill over the past few years is a piece of legislation that would provide a pathway for a digital therapeutic device to have a covered benefit through CMS. So that would be a federal policy that allows for digital therapeutics, which I won't go into the full definition of right now because that's a whole nother webinar, but to have a class. And it just speaks to, something that I think historically, from Jeremy's perspective, CMS did not know that we were going to be carrying supercomputers around in our pockets, right, when it was founded back in the 60s. And so there wasn't a way for, these types of platforms, these types of tools to be paid for. And so that's something that, is being worked on. It's as slow as you would expect it to be in terms of healthcare policy, but it's in the works. And then, we will also work directly with CMS to help providers be able to be paid for their time. And I think that this is something that, can be spoken to by the group. Providers need to be compensated for the time they spend with the patient, whether it's, on a telehealth platform, whether it's using a remote patient monitoring tool, whether it's, facilitating a course of treatment for a mental health disorder via a digital therapeutic. So there are, coding sets for those times that are included in the physician fee schedule. So that's another way that we think about, getting these platforms and devices paid for. And then, some people, depending on their business model, might have a piece of hardware that goes along with the technology that they're using, and they might pursue a durable medical equipment pathway. So as I said, there's certainly not a one-size-fits-all for reimbursement for the tools that are used, as part of a virtual care plan of care. And then I'd love to hear people's thoughts, when it comes to more the reimbursement for, telehealth visits and that sort of thing specifically. So hopefully that was helpful.
And I'll just
Absolutely.
for a second to say that there's a famous book in the history of technology called More Work for Mother, written by Ruth Schwartz Cowan at the University of Pennsylvania. And she charts the history of technologies that are designed to be labor-saving devices in the household over the 19th and early 20th century, right? Like washing machines and dishwashers, et cetera. But then also charts how they actually don't result in ultimately the reduction of the amount of time spent doing housework, but rather an elevation of the standards of hygienic cleanliness of the average American home to ridiculous proportions, right? And the gendering of those expectations of being now part of what it means to be a homemaker. And so one title I was thinking about calling the book was More Work for Doctor, because one of the things that one sees with the development of successive telecommunication technologies is the promise that each of these things is going to actually save scut work, reduce this kind of stuff that one shouldn't have to deal with is bogging down the clinical encounter, and actually allow more time for clinicians and patients to just have these meaningful existential conversations that still, as of today, even as good as AI chatbots are, on some level, only people can have with each other, right? But instead what happens is, it's wonderful that I can finish my chart notes at home, rather than staying in the clinic after hours, because the chart is now a metaphysical concept rather than a physical manila folder, right? But at the other hand, this is what my children know of me. They know me as this person who every night still has the clinic trails behind me because of this electronic platform, right? And I think telehealth brings this promises of forms of efficiency that also cause moments of, enhance the possibility for burnout in this space as well. And this is written about even with telephone medicine. Once telephone nurses reported the burnout and fatigue they got by having to do all of their encounters on the phone, the sheer amount of affective work that goes into developing meaningful rapport with someone through a telecommunications platform rather than one-on-one. And so, rather than in person. So I'm saying all of this to say, not that this stuff shouldn't be happening, but we don't make space for that. And instead of actually understanding that it takes more work to do this effectively through telehealth platforms, the sheer stackability and because people won't need to move from place to place or even walk down the hall, you just zoom in from one into another to another. The capacity for enhanced burnout through this surplus, through this efficiency throughput process is substantial. And so I just want to add to Lonnie's notion that, yes, we need better reimbursement models. But we also need we need ways of thinking about structural efficiency that don't simply create more and more inhumane conditions of care, or we will continue to lose our caregivers.
Yeah.
Absolutely. Thank you for that perspective. I have a question related to that. Are there any research articles looking at stress and burnout in health workers across disciplines?
Go ahead, Jeremy.
Oh, I was just going to say yes, and then defer to you.
I was also going to say yes. And, there have definitely been literature reviews that look at burnout. I think even as recently, when we saw, as Jeremy mentioned a bit ago, I am an occupational therapist by clinical background and am in clinical practice primarily with families and children who are dealing with diagnoses of autism, for example. And when you think about going completely virtual during the pandemic, where people were quite resistant to, having virtual visits before that when it comes to, pediatric OT, which makes sense. It's a pretty hands-on situation. But we all were forced to do it, right? And from the perspective of, literature that looks at burnout, as recently as, the pandemic, with the rise in the number of virtual visits, there have been, studies that talk about burnout and healthcare professionals kind of Zoom fatigue and that sort of thing. And if we go back, a few steps further and we think about, the proliferation of the electronic health record, again, Jeremy, bringing home your clinic at night, I totally get that. There have been studies, of course, that show the burden of technology on the physician from that point of view. Like EHRs were not really meant for the physician. They were meant to, help people keep track of the monies and the procedures, and physicians burned out using EHRs and continue to because of the number of clicks that they have to make, the number of mouse moves, the number of miles they travel on the EHR. So, yes to, are there studies that show the impact of technology as it's developed, on healthcare professionals and physicians, for sure. And I'm sure I could just do a quick PubMed search on the side and pull up a list for you.
Great, thank you so much. Always interested in the clinician perspective on that as well. Well, this is a question for the group, and so we'll just again go in a round robin, whoever can jump in first. I'd like to know, what's the next chapter in telehealth look like to you? And what should we be watching for in the next, say, 5 to 8 years or so?
So I'd like to jump in. It wasn't that long ago that to use a telehealth, to use video conferencing, you had to book a room. And it was an ISDN link, and it cost a lot of money, and you needed to make an appointment for it. And of course, now you can do it from any phone. But still, in many clinics, you have to book that room, or it still has to go through an IT department. So it's still lurching from this telehealth 1.0 type of technology. And I think that what we should expect, and hopefully it won't be 10 years, but I'm often too optimistic in my outlook. I think that if it's not a dirty word, it's going a lot of the telehealth calls are going to be de-skilled, because the actual time that you spend with your GP is minutes. So if there can be more things that are pushed down to nurse practitioners that can handle those calls, much like when you go to the clinic, you're waiting for maybe half an hour to 45 minutes, then you see a nurse that will weigh you, maybe do an EKG, take your temperature, blood pressure, and then you see the doctor for 2 minutes that's looking at your record. A lot of that preliminary work can be done in telehealth. And some of the economics that we were just touching on might not just be driven from a throughput, but may be driven from the necessity of we overburden clinics and less clinics. And also from the payer's perspective, maybe eventually moving more to an accountable care model where they actually do want to be more proactive in making sure that you stay away from needing more expensive procedures. Again, with more insight, if you can prevent heart attacks or push back the need for a valve operation, then you can push some of those costs downstream or avoid them completely. And those economics are going to come into play as we move more towards an accountable care model that will make telehealth a much more necessary, a prerequisite. So I think it's already happening, but it's happening in mental health, dermatology, coughs and colds. There'll be more and more conditions that can be catered for via these platforms, and more devices that plug in. And we're seeing that. I'd like to say it's more like 3 years, that we will see this, but we can have another conversation in 3 years and say it's 3 years out still. But I think it's beginning to happen. And the coming out of COVID, obviously there was a lot of hype around telehealth because of COVID. That was a necessity. And then there was a lot of anti-hype that it was no longer needed. It wasn't urgent. But I think a lot of people realized that there are all sorts of side benefits of telehealth, even if you talk about readmissions. So some of the economic justification might be we can speak to somebody over the next 30 days via telehealth to try and reduce readmissions. And so there are other economic motivations that will come into play that I think will drive telehealth, and a lot of them are going to come from the patient side of the equation.
Wonderful.
Lonnie, do you want to go next?
Go for it.
I mean, I can talk about things I would like to see. As a historian, I don't claim to be a futurologist, right? But I can tell you the history of the future, right? Which is like, in theory, that's the present, but really the present is never actually the future of the past that was imagined in the past. So even if you go back to the very beginning of telehealth and of digital health platforms in the 60s, there's this dream that there'll be seamless connectivity of relevant knowledge for patients wherever they are in the country across providers. And there still is no reason we cannot have that, except for the fact that we exist in the US healthcare system, and therefore there have been a million reasons why we don't have that. But the fact that that again, I'm in clinic today, doubtless I'm going to see someone today who was discharged from a hospital outside of my network and for whom I cannot find that discharge summary, let alone the radiology or relevant lab results, right? And so it isn't, I harbor hopes that we could get closer to that's actually an achievable policy goal. I think if we think only in terms of technological platforms, because this is not a technological problem by itself, right? But, I think there's so much interest in understanding how AI is transforming things. And I think one of the challenges here is we can imagine ways in which AI can be used to transform interfaces such that telehealth works better for doctors and patients. And I think that's partly where Stephen opened up. But in a way, there are ways in which that could have been imagined a generation ago and was imagined a generation ago and still was not implemented, right? So that when I started when I moved to Johns Hopkins and met the director of the residency program, and it was summertime, and I said, how are things going? He said, well, it's July, so by now I know I can recognize all of the residents by the back of their heads. What he meant was we have now elaborated this interface with computer systems in which doctors need to look away from their patients and actually spend a lot of time in front of computers, which takes them away from the bedside, away from engagements. And of course, the technology to undo that was already present, right? Like if you use tablets, if you use things which you can look at someone across, right? If you have scribes, if you have ways such that the technological interface actually takes the scut work away and allows you to spend more time in meaningful communication, we can use these platforms to build remarkable things, right? But in the past, that's not what's happened. So the question is, how do we actually focus on those users in designing the interface in a sustained way, rather than focus on what Lonnie was talking about, like the decision-making being in billing offices. And that's a harder thing to get, just like interoperability is.
I'd like to rebut some of that, actually, as an optimist. So I've seen two revolutions, the internet revolution, the mobile revolution, and been instrumental in some pieces of that. And it's a little bit like a boiling frog. You may remember that there was a time when if you were on, say, AT&T and wanted to send a text message to somebody, you could only send it to somebody on AT&T. And that was because the platform provider, the network, thought it was in their benefit to keep the technology to themselves because they would keep the user in the AT&T network. The technology wasn't the problem. It was the proprietary nature of the incumbents. And in a way, the healthcare system is the proprietary incumbent here. And it's facing an onslaught from AI, from patients, from the internet, from mobile phones, that it won't be able to stop. So wellness will creep into clinical care. And just like AT&T in the end decided to adopt a standard and text messaging went from billions, from hundreds of millions to billions of messages a day. Some might argue that was a bad thing, but it actually took an application, believe it or not, it was American Idol that promoted it. And suddenly, if you wanted to send text messages from other networks, you had to join the club. And the rest is history. But a lot of similar things have happened with other technologies, banking, digital first, retail, of course, digital first. And a lot of the incumbents at the time would have said what we're saying as a healthcare industry. Well, this, maybe the quality of service will suffer. It's not really true retail. It's not really, you don't get the personal touch. But of course, the convenience and in the end, the utility, the capabilities changed. I think we're on the cusp of that. Yes, it will take longer because the infrastructure is really, really broken. But it won't stop the patient demanding digital first. And in life-saving situations, that's going to become something that is going to be unstoppable. And we're finding other advantages. Compliance improves when you have these kind of digital connections. So I think that we are experiencing the boiling frog, and I think we're getting near to being boiled at the moment.
Yeah, I mean, I like your point here, Stephen, because, simply the statement that these things haven't happened in the past can't be read as an excuse for fatalism in the future, right? So the question is, how do we attend to those kinds of levers that actually produce transformational change? And I hadn't really thought of American Idol and healthcare, but I'm gonna meditate on that for a while.
Okay.
Wonderful.
I think that to not sound too simplistic, but to make the point that, as we move these technologies forward, as we become digital first in healthcare, that the way that we should be thinking and are thinking now is that virtual care is healthcare, right? It's not some other thing. It is healthcare. And, to both Jeremy and Stephen's point, my hope for, the next few years, and again, we can have this conversation in a few years and maybe have to push out because of the complexities of our healthcare system, but patients will be driving the demand for healthcare in the ways that are accessible to them. So, I just want to emphasize that, this virtual care that we're talking about is healthcare.
Excellent. Well, thank you so much. We have had 3 questions come forward in the chat, and thank you again so much to our panelists for this exciting discussion today. One of our questions is, most of the advances made in remote or telehealth have come from the space industry, which is delivering care to extreme remote environments. Are there partnerships being made in the aerospace industry?
I'll start off by just saying that, one of the first telehealth programs delivered to rural areas in the United States was the StarPack program, which was basically what happened when initially pivoting from Apollo missions to Mars, but then ultimately towards what became the space shuttle. The Lockheed Missiles and Aerospace System designed this telehealth system that needed to be, this was going to be the telehealth system for the space shuttle, needed to be tested in human populations. And it was tested among were then called the Papago tribe of Southwest Arizona, now known as Tohono O'odham, basically taking this telehealth system that was going to be in the space shuttle, stuffing it inside of a Winnebago, driving it around the Sonora Desert, picking up sick, Papago, Tohono O'odham, and then but treating them as if they were astronauts. And so this partnership was fascinating and groundbreaking. It like so many other things, worked. It wound up being very good for NASA because it cleared the bay for use. It was also good in some ways for the Indian Health Service, and its legacy for the Tohono O'odham was more ambivalent, right? Several people who participated in it helped to build this network and became involved in developing tribal health services. But at the same time, even though Arizona is one of the states that has the richest and most rapid and thorough deployment of telehealth services in the country, until the COVID pandemic, the Tohono O'odham had actually been left off of telehealth networks. So that's a brief answer of saying, yes, that has historically been a vital and robust connection, but how and for whom the durability of the benefits actually translate terrestrially has been very much up at stake.
We've had some interesting research projects in the past that involve the questions of how can astronauts have an onboard clinician. You can't necessarily staff your rocket ship with cardiologists, pulmonologists, dermatologists, mental health. So how do they relay data in real time to expert systems and get help and taking devices on board like stethoscopes, where you've got to be mindful of the real-time nature of the device, the cost of the device, the weight of the device. So all sorts of questions that are very interesting, but even cybersecurity, because everything's anonymized. But if you anonymize, but that the location of somebody is roughly in America, that's still anonymous. But if there's just 3 dots of people in space, that's no longer that anonymous. So very interesting technical questions about solving problems in space, and hopefully, like Teflon, it will translate in some way to being useful to the consumer eventually as well.
Thank you so much. An additional question that came forward is, what can we do to ensure telemedicine continues to expand instead of regression to only remote areas? This individual champions a rare disease, and she has patients. She or he has patients in many states. Will they be able to provide this care across state lines, given that this care is limited by providers with training in this area?
Yeah, I think, as Jeremy said, the question is no longer about rural. There's equal problems getting to see a doctor in urban areas and other related questions. So I think this is not just a rural issue, although it's more pronounced in rural. And we certainly see a huge conversation around credentialing, so that providers can deal with patients across states. I think that's going to happen. We've even had conversations with opportunities outside of the US to offer similar capabilities. I think that's going to happen as it's digital, as it has done in other markets. So I'm hopeful for your questioner that this problem will be resolved. Again, it's not technical; it's political.
It is, and certainly the ATA, thinks about the credentialing question with our providers all the time, and I agree with Stephen. We'll get there. We'll get there.
Speaking as a teleprovider, something I'd love to see roll out is helping people understand what kinds of things they can do well versus not do well through telehealth encounter. And, again, certain number of my visits this afternoon in my clinic will be telehealth visits, but a certain percentage of them will be very frustrating because there are things where I really need to actually see, be able to lay hands on their belly, and so won't be able to do the encounter. And so it's wonderful, like bringing someone into a clinic for something that we could do in a telehealth call is it should be understood at this point as a bit of a travesty unless there's clear secondary value in actually, reaffirming our clinical relationship through all of this, right? But actually promising someone value through a telehealth visit when it doesn't actually get delivered is also a travesty. And so I don't know how we can better educate the public about this, but it's almost something that is pushed out when telehealth visits are offered as a better understanding of what can and what can't be delivered through a particular channel.
Yeah.
Excellent. One more question. We have time for just one more. What about virtual reality visits and avatars?
So I'm going to reverse my optimistic perspective and say that technology shouldn't be there for technology's sake. It's great for headlines and it's great for movies, and it might be great in certain opportunities like remote operations. But I think we're struggling just to do a remote exam where we're listening to somebody's heart and lungs, stomach, or taking an EKG. And we're also struggling to say that there are many people that can't afford the equipment. So the day when virtual reality is going to be an everyday experience, maybe more than 5 years out. Certainly there's augmented reality, if that sounds equally sci-fi, but it's much more practical. There are overlays to our screens. There's a background that we're not all in a red background. We use overlays that allow doctors to navigate a target on your heart so that the patient knows where to move, because otherwise the patient wouldn't know how to auscultate themselves. So there's augmented reality that's here today and very, very useful. But whether other wearing Apple visors and things is going to be an everyday thing is in my opinion is somewhere further downstream.
Yeah.
Great, thank you so much.
That we, in terms of VR, we need to just look at what conditions that VR headset that's immersive may be indicated for. And at this point, I think that there are a few that are showing great promise in terms of outcomes. But, to Stephen's point, is that a ubiquitous, piece of technology that's being used across telehealth visits? It isn't. So yeah, it really comes to clinical evidence for, its use.
And I'd come down again always to for scale, it needs to be easy to use and it needs to be affordable. Otherwise, it could be really great for a small number of people, but it's not going to be an everyday occurrence.
Great, thank you. Thank you so much today to our panelists, Dr. Jeremy Green, Stephen Randall, and Lonnie Riley for sharing your expertise and your insight on our webinar. What we've heard today is that telehealth is no longer a temporary solution. It's a vital part of our healthcare future. By combining historical perspective, innovative technology, and a focus on equity and access, we have the opportunity to shape a next generation of telehealth that is more integrated, more personalized, and ultimately more impactful for patients and providers alike. Before we close, I'd like to invite you to join us for our next webinar on Wednesday, October 22nd at 12 p.m. Eastern. The topic will be calculating your disease risk, a look into the American Heart Association's Prevent Calculator. This session will be moderated by Dr. Don Lloyd-Jones of Boston University with expert panelists, Dr. Sadia Khan, Dr. Tushar Palakar, and Dr. Mujib Basit. They will explore how the Prevent Calculator is advancing risk prediction and prevention in cardiovascular medicine. And finally, a reminder that the American Heart Association's Health Innovation Pavilion will take place at Scientific Sessions this year in New Orleans on November 7th through 10th. We hope you'll join us for more opportunities to connect, learn, and innovate together. On behalf of the American Heart Association, we thank you again for being part of today's conversation. We look forward to continuing this journey with you, and we'll plan to see you on October 22nd.
Thank you.
Thank you.